Access to potentially life-saving mammograms is more difficult for women who face social determinants of health, such as low income, lack of transportation, or the inability to take time off from work. In Dallas, Parkland Hospital Health System is focusing on reducing cancer disparities by addressing these health-related social needs. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hederle, Senior Writer for AHA. Using data generated by the Parkland Center for Clinical Innovation, an independent collaborator, Parkland Hospital Health System has identified women at risk for breast cancer who are economically vulnerable and experience challenges accessing care. The data allow Parkland to pinpoint high-risk neighborhoods and zip codes and send mobile mammography units directly to residents most in need. It also gives caregivers a better understanding of how linguistic and cultural differences can be overcome to provide more effective care. The Parkland model hosts lessons for care providers everywhere. In today's podcast, two of its experts explain how and why their model is making a difference. Our moderator is Julia Resnick, Senior Program Manager with AHA. Julia?
Thanks, Tom. Hi, I'm Julia Resnick, Senior Program Manager at the American Hospital Association. This podcast series is part of the Value Initiative, which highlights how hospitals are improving value and affordability for their patients and communities. These members have implemented strategies that enhance the patient experience, improve quality and outcomes, and lower cost. In today's Members in Action podcast, I will be talking with Vikas Chowdhury, Chief Analytics and Information Officer at the Parkland Center for Clinical Innovation, as well as Teresita Oaks, Director of Parkland Hospital's Community Health Programs in Dallas, Texas. They will be sharing how Parkland is detecting and addressing patterns of inequity around breast cancer. Vikas and Teresita, thank you so much for joining me today. Let's jump right in. I think it will be really helpful for our listeners to start with some background on Parkland and PCCI. Can you tell us about your community, your hospital, and PCCI?
Parkland is the Dallas County Public Health Hospital and Health System. It was established in the late 1800s in response to the need for low-income individuals that were seeking care. And since then, it has grown. It is one of the largest safety net hospitals in the nation. And in 1 year, we can have, a million patients or a million individuals that come through our doors. So that just gives you a dimension of how large our hospital and our community service area. And also, we have a very strong presence in the community with outpatient clinics. We also have a unit that provides services to the homeless.
And PCCI, which is Parkland Center for Clinical Innovation, is the advanced analytics and machine learning partner of Parkland. We are autonomous, not-for-profit organization, but we were actually incubated as a clinical innovation center out of Parkland Hospital and were later spun off as an independent not-for-profit. And one of the early successes that we had that actually brought a lot of recognition to PCCI was a readmission model that included social determinants of health as one of the predictors. It included housing instability as one of the markers for 30-day readmission. And it was a very successful model that outperformed pretty much every other clinical database model that was published at that time. So from there, we got our start. And over time, we have continued to align very closely with Parkland, focusing on vulnerable populations, looking at Parkland's role as a safety net hospital, and then also working a lot in the community to see how we can really address social determinants of health using advanced data analytics, using AI, so that individuals receive appropriate care in the communities before things deteriorate so much that they have to show up in ED or have to get an admission.
Great. That's really helpful and a really unique model to have the innovation center that is connected with the hospital. So I know that you all are working together on social determinants of health. Can you be a little more specific about what social determinants of health problem you're trying to address in your community?
From PCCI's perspective, we are primarily looking at three areas. We are looking at how social determinants of health can impact patient safety and quality within the hospital. And then we are looking at some of the most vulnerable populations from the aspect of behavioral and mental health. And then we are looking at some of the polycomplex chronic condition patients with asthma, with diabetes and other conditions. And what we're trying to do is, as we are analyzing the data for those patients and trying to look at the predictors that can be used at point of care, we are just not looking at clinical data. We are looking at housing instability. We are looking at transportation needs. We are looking at economic data. And we are trying to bring it all together to create a more actionable point of care analysis for case managers, for nurses, for clinicians, which can then be incorporated as part of their interventions, so that when they're thinking about taking the next step for those patients, it's not always clinical or a pharmacological intervention. It can take other forms that could include a housing referral, that could include a food pantry referral, that could include transportation vouchers, and all the other things that go kind of in the environment where these patients or where these individuals live. Teresita, what would you like to add from your unique perspective?
Yes, so from the hospital and the health system perspective, what we're looking at is that we have, our mandate is, as I said earlier, to address the health needs of the low socioeconomic population here at Dallas. So with that said, you already know that your population is going to be experiencing some challenges with some of the social determinants of health, which are, the places where they live, are born, play, work, and so on and so forth. So what we're really looking at is, from a health disparities perspective, is how these social determinants of health really shape and influence the health of the communities at large. And then how can we use the knowledge that we obtain through collecting this data to identify those populations that are most likely at risk for severe disparities? So through this project, one of the things that we have identified is that in these zip codes of interest, we have found that there's a significant higher percentage of woman-led households than other zip codes. This, to us, was a very important finding because it really emphasizes in the need to really focus outreach efforts in these zip codes where women are really the main providers of their households. And it begs the question that if we don't do this right, what happens to those family or children or parents who are economically depending and, of course, emotionally depending of the women who are in charge of their economic well-being?
So how did you decide what areas to focus on? It seems like there are any number of options out there. What guided you towards an intervention?
Well, this is why data analysis and using data to make informed decisions is very important. This work was born in response to some of the needs or requirements that we need to fulfill with the Commission of Cancer requirement, which is that a hospital shall have a community health needs assessment and should have a program to prevent late cancer diagnosis. So in looking at different data that we have collected, we have a cancer registry that we looked at, and we had already here in some of the presentations that the doctors have been doing that there seemed to be kind of a higher number of late breast cancer when they started to dig more into it. So we took a deep dive into it, and what we found that indeed the percentage of late breast cancer diagnosis was about 21%. And what was also interesting was that as we look at the data, we found that these cases were coming from two zip codes, and the demographics of these two zip codes were very different. Whereas one had a high concentration of African American population, the other one had a high concentration of Hispanic. However, they share some of the low socioeconomic status. They were further away from, or they're located, as you will, in a health care desert zone. They also were characterized by difficulty in accessing public transportation and how to get to places where, services are readily available. That is really what led to start the work, just looking at how can we use the data that we already have and what can we learn. And as we began these discoveries, we felt it was very important that we focus on a health equity strategy in these two communities.
Great. Vikas, anything you wanted to add there?
So Teresita mentioned about looking at data, and that's where we were fortunate enough to partner with Parkland. And we helped Parkland look at that cancer registry data to really analyze trends there and figure out kind of what was going on within those zip codes. And one of the interesting things, again, talking about Teresita talking about looking at data and making data-driven decisions, intuitively, one might think that a lot of the late breast cancer diagnoses might be very much along the racial lines, but we did not find that. And Teresita, please feel free to add to that, this particular aspect. What we did find was that this was more a socio-economic situation rather than strictly along racial lines. And I feel that's really where it's important to look at data objectively and let us use data to guide those decisions, because there is just intuitive sense of how we think about problems. And then if data takes us in a different direction, we should be willing to do that. And that's what we found between our partnership, that when Parkland's group looked at that data and understood that this was along more socioeconomic lines, kind of more the situation that we've understood around urban poverty, they were willing to apply that different lens to what the interventions could be and how we solve the problem. Teresita, did I characterize that aspect appropriately?
Yes, you did. And definitely, I want to really highlight the power of data-driven decisions to do outreach, engagement, and design interventions, because one of the things that PCCI was instrumental in helping us was to identify some of the background of these late breast cancer diagnoses. So to me, something that really caught my attention was that 52% of these cases were from women who didn't have a previous history of a mammogram. So while we have not completed, this project is still ongoing. One of the things we want to look at the next steps is whether these women had a history with Parkland prior to coming to being diagnosed with breast cancer. Why? Because first we want to see if that was the reason why women come. We have a theory that we believe that this might be the reason why women came to Parkland. And if this is happening with breast cancer, we are also concerned that this is happening with other diagnoses. And we already have some other topics of interest that we want to follow the same logic or process that we did for this particular project, because we believe that given what we learned for this project, that people are so busy with their personal lives that by the time they get to seek care, the complexity of their condition is very advanced, if you will. So learning that was very important. And when we look at our larger data set of all our patients in Parkland, the highest volume of our patients are one-time patients. They come for one time, they get their issue solved, and they don't come back. We don't know why that is, but looking at this data, we believe it has to be tied back to the social determinants of health.
Absolutely. And it seems like you all did a really deep dive into the data to figure out what the issue was and why it was occurring. So now I'm really interested in, once you learn that there are these inequities in breast cancer detection, what did you do to address it?
One of the things that we're currently doing is we are revamping our outreach campaigns. How do we go out to the community and place our mobile mammogram units? So we are looking at, it's interesting you asked this question today, because yesterday we had a meeting, and right now what we're doing is really taking a deep dive of how we make the decision to deploy the bands. Where do they go? What are those decision points that we use to deploy a mobile unit? So we were going through, what are the questions do we ask those who outreach to us? Who is the demographics? What is the age group? How many people are going to attend? So we're doing that so that we can look at it. Are we missing key questions? Are we screening these requests to be appropriately? are they yielding enough screenings, or do we have to revisit? So just in the early discussions, one of the things that I believe is going to change is that we need to take a more proactive approach and shift from expecting, ideally in our current state, the community-based organizations come to us and we have some outstanding partners that it's worked, but now we're thinking, okay, wouldn't it be better if we put a series of guidance? If you want a mammogram mobile unit to attend your event, here is what we need from you. So that we are educating those zip codes where we're most likely to see disparities on what it is important to have ready so that when we show up, we're more likely to have a higher volume of women having their mammogram done.
Great. Vikas, anything on your end?
And I think something that's also has become very important, one of the things that we learned in our focus groups is how many women said that the complexity to apply for Parkland's financial assistance program. Mm-hmm. And what we learn is that we need to provide better outreach to educate women to have this done before they schedule their mammogram, because if they wait at the last time and all their paperwork is not in order, it makes it a little more difficult. But more importantly, if there is a concern that needs follow-up, having this ready expedites your treatment. So we have been meeting with a lot of community-based organizations that have high volume of contacts with our patients or our population. And we've been discussing with them, how can you provide education on the importance of having this ready? We have also been revisiting our own internal processes for the application of this assistance. So it's a little more streamlined, a lot easier to understand, and more efficient. Because as with any new effort, the demand for services increases is going to have unintended consequences or impacts in other divisions, and we need to be sure that they're ready to respond to the higher demand that might come in response to our educational strategies or interventions.
Mm-hmm. I think what you're talking about really illustrates the power of asking questions, not just asking questions from your data, but engaging your community and really understanding what their needs are so that you can shape your interventions around them.
Absolutely. I appreciate your observation, because I think one of the most powerful things that this project did was that we conducted 12 focus groups throughout the community. We reached out to more than 100 women. And I really want to give a shout out to PCCI on this, because they were instrumental in helping us do the data analysis for this qualitative data. And it was fascinating to hear and listen directly from these individuals. But now we have tangible, qualitative data that gives us informed decisions that is directly from the experts, which is the women in our community, rather than us hypothesizing or just, believing what we think it is, whereas really asking the experts on these topics.
Yeah, absolutely. And for the intervention piece, obviously, that was in Parkland's wheelhouse, and Teresita covered pretty much everything really well there. The only thing that I would add, Teresita, is the work that we did for the correctional health data, which is very unique because Parkland provides healthcare facilities for the correctional health system for Dallas County. And we were actually able to analyze correctional health data. It's a very unique population, often neglected in terms of what their needs are. And when we looked at that population for 2018, we found out that 25% of the incarcerated individuals were females. And out of those, there were 20% that were eligible for mammograms. And almost all of them needed immediate screening because they had no screening within the last 1 year. And the reason why we were able to do that is, interoperability is always a big thing in healthcare. Data is not always interoperable. That's a big concern for everybody. And so the electronic health record systems are different. At correctional health, there's a different system, and at Parkland, there's a different system. And we were able to use some of our machine learning patient matching algorithms to match the patients between the two systems to really be able to see what was their medical history in Parkland, whether they've had any mammograms in the past 1 year or past 2 years or not, and we're able to surface those numbers more accurately for Parkland. And I believe one of the interventions that is being considered right now is to provide mammography functionality within the correctional health medical facility itself so that some of these concerns can be addressed. Teresa, would you like to add anything else to the correctional health part?
Yes, absolutely. And thank you for bringing that up because that kind of escaped out of my mind. But that was very important work because, talking about social determinants of health and how this work has really influenced what we here at Parkland are doing, we just completed our triennial community health needs assessment, and we identified that the majority of the patients that are incarcerated in our correctional health system come from these two same zip codes where we see the higher number at risk breast cancer diagnosis. So that was, wow, think about the impact. Then out of that finding that Vikas just described here, we have now in our pipeline seeking the opportunity to maybe bring a mammogram unit to the health system in the correctional health. So that will get, or can we just, coordinate that with our own efforts here within Parkland? So we have just uncovered so many things and so many opportunities that I really think is raising the bar on how we can really improve our outreach and use data to make informed decisions in designing the interventions to reduce these disparities.
That is really fantastic. So I want to move on to talk about the impact of the work and what kind of impact you're seeing for the hospital and for your community, recognizing that this work is ongoing.
Okay, so that question is loaded because we have many things that are coming. So I think one of them was to recognize how do we do the outreach in the community to increase mammograms. The other one is the impact of improving our patient financial assistance program so that they can access the services. Other one has been, we've been working, Parkland also has a Parkland Community Health Program, which provides insurance under Medicaid. And how do we increase outreach and engagement in these zip codes? We are also meeting with some of the other community organizations that have a high volume of patients or clients that are also our patients and clients so that we can work together to address some of these issues. We are working together with the American Cancer Society so that we can ideally continue in a collective impact approach so that we can collectively with other organizations that are also addressing breast cancer, we can work together towards the common goal. However, I would say the most important thing that has come out of this work is that we partner with community-based organizations that are small in nature but mighty in outreach, and I'll give you an example. One of them is a church that also has a food bank, and because they have a food bank, the volume of patients or individuals that come across this organization is huge. So we have partnered with them as a linkage to the community. They're very well trusted. They have a very diverse population. But I also perceived that this is the population that is not coming for services because they spend 3-4 hours on a line to get food maybe twice or 3 times a week. So as we've been visiting with them, we have learned that the social determinants of health is not only the lack of thereof, but also the demand and the time for these individuals to have to get in line to pay, apply for some assistance for their bills. The time they spend online or using public transportation, it can take them 2 hours to get here, 3 hours to a grocery store, and I'm not making this up. or they lined up at 4 a.m. to get the food for the next 3 days. So when you look at the limitations that the state of the social determinants of health has, we have learned that these community-based organizations have a significant role in the health system, which has really helped us bring services and partner with them for education, to provide services, to communicate directly with the members, and build trust and just be with them within their own natural settings rather than having them come here when they have all these other competing priorities.
Mm-hmm. Those are great insights. Vikas, any thoughts on impact of the work?
We were just delighted that we could work with Parkland on such a meaningful project and actually look at all the impact and future potential possibilities of impact that this project could be doing.
And I want to highlight the work that PCCI did with us with analysis of the focus group. So a couple of things that come to mind is they analyzed the language used, and having that quantified for us was very powerful, because what it showed is the value of listening the patients in their own language. So I'm going to give you an example. The common word used within Hispanics to describe Hispanic women to describe abnormalities in their breast, they use the word bolita, which means a little ball. But in English, when you translate that, we automatically say a knot or an abnormality. But if you translate that back to Spanish, it doesn't mean quite the same. Mm-hmm. So learning how the language that is used to describe a symptom or a condition in the terms and in the culture of the person who's in front of you, it was very important. The other thing that the work that PCCI did was able to quantify the impact or the value of doctors and nurses talking to the women about breast cancer. When we asked that question, who do you feel more comfortable? It was, how to say clearly, that doctors play a very important role. And we normally assume that these community or these populations don't feel comfortable talking to their doctors. Well, they burst that myth right away. And then the other thing, and I really want to quote Manjula, am I saying her name correct, because?
Yes, Manjula, Dr. Julga.
Yes. So she provided some of the oversight of the data analysis for the focus groups. And one thing that I perceived, because I would say I went to most of these focus groups as they were talking, is some anxiety, some fear in talking about this. And to me, it was very interesting that when we were presenting the results of the data analysis, she was able to say, yes, this causes concern. And the word afraid, and she was telling me she felt that the apprehension, if you will, in looking at the data. So in looking at that, what it was interesting is that the data analysis also identified that most women are afraid of mammograms because there's a general belief that a mammogram is to confirm cancer rather than early detection. So that was a significant finding for us, because how we go about educating is going to change significantally. Mm-hmm. And, highlight the value of that in breast cancer is not preventable. It's early detection is what we strive for. So really providing that education was very, very important. And having that in a document and in a data analysis, it was very, very powerful. But, when we looked at this, we said, well, why is this happening? We couldn't put our fingers on it. Now, since we did that focus groups and we did this data analysis, we recently released our community health needs assessments, and we found that the 2 zip codes with the highest cancer mortality for all cancers are these 2 same zip codes. So, of course, there was that fear, that anxiety, apprehension that we were feeling was validated, because when we asked, what do you know about breast cancer in your community, they talked about all cancers. And that was reflected in our CHNA.
Very interesting. And I think You've been starting to get at some of the lessons that you've learned about the importance of language and not making assumptions. Vikas and Teresita, what else have you learned from doing this work that you think would be useful to other hospitals who might be trying to undertake similar initiatives?
From the hospital perspective, I think the most important thing to me is the value of community-based participatory research, which is a public health strategy that has been used a long time, where you really involve the members of the community or population that you are trying to solve an issue, because they are the experts on their community, on themselves, on their culture, on their realities. And if we don't include them, we are more likely to ignore the important points that we need to be aware of, and that we are equals. We have a very historic medical model where, healthcare is above the population. But really, we need to look at ourselves as partners. And if we don't understand these idiosyncrasies and these unique realities, one thing is to say, yeah, they're all in food stamps. But when you look at the time they invest in food banks, the time that they invest going to access the best grocery store that's within their community, we really do not understand what we're asking our patients to do. So really bridging that by really sitting down and involving them in designing these programs will make a difference. And from the data perspective, what I would like to ask, because what was their experience in doing qualitative analysis with text analytics?
Yeah, I think that's one of the lessons that I would add. Quantitative data, clinical data from the EHR obviously is very important, but it is equally important, or if not more important, from a point of view of actionability. Right? What are we going to do? The qualitative data and analysis of that qualitative data, really understanding the patient story, is incredibly important as hospitals design interventions around, access and education and all the other factors. And oftentimes, analysis of qualitative data is not scalable, right? You have hundreds of surveys, and you can make sense of the structured responses in those surveys. How do you make sense of the unstructured responses there? And we were able to apply some natural language processing techniques and kind of create a framework around those responses to truly understand at scale what did the response indicate, whether it indicated an access issue, whether it indicated a family support issue, whether it indicated an insurance issue or transportation issue. So I thought that that's an important thing for hospitals to understand kind of as they go out in the community and understand patient stories. How do you analyze that qualitative data to understand kind of what kind of pattern emerges? And more, some of these machine learning techniques and some of the NLP techniques around that data start becoming very important if you really want to scale some of this work.
And to expand on what you just said, because to me the biggest power is it doesn't tell you what the issue is, but it describes it. So, for example, we know that, access to care is one big social determinant of health, but what about access to care are our members really telling us? So the challenges in applying it, the lengthy process for insurance coverage, navigating insurance coverage, that was one issue. The other issue was the time it takes them to access a mammogram unit. If it's not a mobile and they need to come within our facilities, that takes them a very, very long time. The other aspect of access to care was also, how do they take time off out of their 3 jobs when the women are their sole providers? So the availability of services at the right time for women who have multiple jobs and are the sole providers, and they're not in line for food or for other things that, or, taking the kids to school or all these other things that women do. So when you start really having that description of what is about access to care, we're able to do much better design interventions, because now we have a better understanding. It's not just insurance, but what about insurance? It's not just about making the services available. Is that their schedules are so transient and changing from one month to the other, that is difficult for them to make those arrangements. So what can we do differently? Wouldn't it be the ideal moment we put a mobile clinic in these food banks? So these are all the questions that now we are starting to look at from the perspective of the members, but with much more deeper knowledge than just its insurance is the time of the services availability. It's the time that the transportation is available to them. It's much, much deeper than that, what we learn.
Absolutely. And I think that qualitative piece is so important. I'm so glad that you're both bringing that to light in the work that you're doing. So in closing, I want to think a little bit towards the future and what's next for Parkland and PCCI in this space.
Oh, a lot of exciting things. Since the release of this project, we have we haven't stopped the work. We continue to do the work. So to ensure continuity, what we're going to be doing is part of our community health needs assessment that we are required to do every 3 years. Also uncovered that these two zip codes have the highest mortality rates for all types of cancer. So we're going to continue to work in these zip codes. We also have identified, and because I was just sharing this yesterday with Steve in a meeting about our larger health disparities issues, is how do we come together to create a common data management information system that can help inform the county at large to make these informed decisions. The power of sharing all this work with other hospitals in the region, with other community-based organizations or institutions that do work on this space. But how do we all come together? So I think that is very exciting. I think the other aspect of this work is that we have now raised the bar in how we're going to put our processes in place to make future decisions, not only for breast cancer, but all other diagnoses and conditions. The lessons learned from the social determinants of health really has taught us a lot in how to look at things differently and how do we include the perspective of our patients throughout our decision-making process, and partnering with those local organizations that deal on a daily basis with these populations. So I'll stop here because I can talk about this all day, but because anything you want to add?
Yeah, absolutely. So from PCCI's perspective, we are excited by a few possibilities. One is, in the context of this late breast cancer diagnosis work, expand this across the state. I believe we are waiting on getting some approvals to do similar analysis for Texas Cancer Registry data, just like we have done for Parkland's data. And I think that will be hugely meaningful for a state as big as Texas. The second thing that we want to do is kind of go granular. So healthcare is not only local, it is hyper-local, right? So we have done this analysis at the zip code level 216, 217, but we have the capability to go down to block group level because there is a lot of variability within neighborhoods, within those zip codes. Some neighborhoods might be up and coming, they might have better facilities, and some neighborhoods might be kind of on their paths to deterioration. And we would like to be able to tease out those things from these block group level indicators so that the interventions or the type of functionality that, say, Parkland or other community-based organizations provide in those neighborhoods can be very precise based on what we are seeing in those neighborhoods, and it's not just a broad kind of zip code-based strategy. And like Teresita said, we are excited about kind of taking this framework that we have developed for late breast cancer diagnoses to other conditions, other situations facing vulnerable populations. Things like preterm birth, things like postpartum depression, other chronic conditions that might be prevalent in those communities. So take the same framework, take the same kind of analytical foundations that we have developed, the data models, and then help Parkland apply to other conditions to address some of the other needs in the community. So that's something that we are looking forward to doing.
Oh, that's all great, and it certainly sounds like the two of you have your work cut out for you. So with that, we will wrap up. Vikas, Teresita, thank you so much for doing this with me. This has been really interesting and I think important to illuminate the power of asking questions and using qualitative data when designing your interventions. So thank you.
Oh, wonderful. Thank you so much for all your help, because I think working with the AHA has made it very powerful for us to showcase the work, and internally it's gotten a lot of attention. So the power of this partnership has been tremendous. So thank you.
I am so glad to hear that. So thank you both so much. For more podcasts and additional tools, resources, and education to help you promote value in your community, please visit the Value Initiative's website at www.aha.org/thevalueinitiative. That's it for today. Thank you for listening.